Good evening, everyone. My name is Mitch Wasden. I'm the CEO of MU Healthcare, and I am excited to talk to you tonight about some patient engagement strategies that we have at MU Healthcare in conjunction with Cerner and our Tiger Institute for Innovation. But first of all, let me tell you a little bit about who University of Missouri Healthcare is. We're about a $1.2 billion organization with 7,500 employees, 7 hospitals, 500 doctors. We're located in Columbia, Missouri, and we recently were listed as a most wired hospital. And also, just this last month, we were rated by the University Healthcare Consortium, which rates 130 academic medical centers across the country, as number 9 in the nation. So, when we look at some of these outstanding accomplishments, I'll take it. We'll take an untimed clap. When we look at a lot of our accomplishments, it was the partnership of a lot of doctors and nurses, but we think our partnership with Cerner definitely has played a huge role in some of the things we've been able to accomplish recently. So today, I want to talk a little bit about a problem that we have in healthcare. And the problem is that everybody seems to want to be the aggregator. And so when you talk to a health plan, they say, well, we've got all this patient data, we want to be the aggregator, and we want to shell out the information as we see fit. And when you look at physicians and hospitals, they say, well, we've got the EMR, we want to be the aggregator, and we want to shell out information as we see fit. Or you look at health information exchange providers, or you look at employers. Employers have wellness and claims data that they say, we want to be the aggregator because they're our employees and we're paying the bill. The problem is all of these parties have an IT system that has been built for them so that they can be the aggregator, so that they can affect patient care. But the problem is this: who's the most important person to engage in healthcare if we want to see patient outcomes improve? The patient. Who's built a system for them? Where's their IT system? It's almost so obvious, it's amazing that people didn't see it. And so we say, well, they've got this little app that can do this and this little app that can do that, and there's all this flurry of activity out there, but nobody's aggregating it into one solution. And so the question we have to ask is, what does the patient want? What does the patient want? Well, the patient, as we move into consumerism, the patient, they want to own their health care. They want to control it. They want to be able to afford it. They want to be at the center of it. Okay? They want to be at the center of it. So let's talk a little bit about centers. In the 1500s, a gentleman by the name of Copernicus was trying to calculate the alignment of the planets. And as he was trying to calculate the alignment of the planets, he kept getting it wrong. And every night he would go out and look in the night sky and he would say, okay, this planet should be here, this planet should be here. And they never were where they were supposed to be. And he got really, really frustrated. And so his models got even more complex and more elaborate, but then it still wasn't making any sense. And then he asked himself a simple question. His model was based on the Earth being the center of the universe. And so he said, well, what if the sun is the center of the universe? And when he put the sun at the center of the universe, amazing thing happened. All of his calculations worked. The planets were where they were supposed to be. And so what we learned from Copernicus is that when you pick the wrong center, you get the wrong solutions. So we look in healthcare and we say, yes, it's all about the patient and it's patient-centered and blah, blah, blah. But let's be honest. When we design, especially in technology, IT applications, how many times are we designing them with Joint Commission as the center? With CMS is the center, right? With payers is the center. Let's be honest. That's what we're doing. And so we have to take this different view and say, so what would I design if I really, really wanted the patient to be at the center? What would I be designing? The beauty is we're living in a time in American healthcare where there are forces that are pushing patients even more to the center. And consumerism and the emergence of high deductible plans, we have all these millions of people going on to health exchanges and whatnot, and for the most part, many are picking high deductible plans. is making patients on the hook for the first $3,000 to $5,000, and they're saying, wait, I want to know the cost. I want to know what the quality is. I want to know some of these things so that I can actually control and own my health care. So let's talk about what it feels like to not be at the center, okay? I call this scheduling gone wild. Rewind about 50 years ago, when you called a physician office and you said, I wanted to make an appointment, there was somebody on the other end that had a paper book, and there were like two flavors, long and short, right? You had two appointment types. And then this amazing thing happened. Healthcare IT came into the scheduling world. And we got so excited because now we could have 60 appointment types, right? I talked to somebody this morning who said that their organization has 600 appointment types. And we got so excited that we could have that many appointment types and that we could do it that we never asked ourselves the question of if we should do it. The problem is, as you create more complexity in the healthcare system, the patient gets pushed farther and farther away from the center because they can't comprehend it. We can barely comprehend it, right? So we go down this road of going from ICD-9 to ICD-10. Is that pushing the patient closer to the center or farther from the center? Anytime we introduce complexity, it is pushing the patient farther and farther away. So we have to redesign healthcare. And so that means that there's these certain tasks that we have to do differently. And so now we have to ask ourselves, well, maybe I need to figure out what is the task that I need to do differently. And to know what the task is, we have to ask ourselves, what's the essence that we're trying to solve? What's the essence of it, right? And so if I was going to say, what's the essence of a clinic visit? Okay, the essence of a clinic visit is, I have a patient and they have some information. And they need to bounce that information off somebody with specialized knowledge. That's the essence of it right there, okay? But what do? What we do is we say, well, okay, here's a physician visit. First of all, I want you to call the clinic. Tell them you want an appointment, and then they're going to tell you they can't see you today, but they can in 2 weeks. And then they'll say, well, gal, I really need to get in. Let me ask the nurse. So you go and ask the nurse. And then the nurse says, well, I obviously can't make that decision myself. I have to ask the doctor. And so then the doctor is asked, and then the doctor says, yes, that's okay to the nurse. And then the nurse tells the front desk that's okay. And then the front desk tells the patient that's okay. Then the patient comes in, and they come into the waiting room and fill out a bunch of forms, and then they wait. And then the nurse pulls them back to the waiting room and asks them, surprisingly, the same questions that she just filled out on the form. And then the doctor comes in and asks for the third time the same questions that were on the form. And then the nurse comes in and says, you're free to go, and then you may check in at the front desk. So we took something where the essence was one step. I have some information, I need to share it with somebody, and we put 10 to 12 steps in between it. That doesn't feel centered. So if we're going to go down this journey where we want to redo healthcare a bit, we have to introduce ourselves to this concept that Joseph Schumpeter made famous, where he said, and he was speaking of capitalism, he said, capitalism is creative destruction. And that sounds very scary and like not friendly, and healthcare is kind of a friendly place, but here's the problem. We've created this structure that's super expensive, that the health outcomes aren't that much better than other parts of the world, and we have to get comfortable with the fact that we've got to destroy some things. We have to have the heart to destroy some things and almost be irreverent about the things that we've created so that we can actually create an industry that is what the patient wants and actually puts them at the center. And so with this innovation cycle right now, we're kind of lower than stability, close to destruction, and then destruction is going to happen. It's going to feel like chaos, and then we'll have an innovation. So let's talk a little bit about some innovation. So in the patient portal at the University of Missouri, we had this question. And we said, okay, there's all these steps to basically get a patient to have an appointment. What if we did something radical like the airlines have done, or my wife's nail salon, or the haircutting place, and let you book appointments online? Okay? So just do a little thought experiment. What if we did that? And immediately the answer comes back, oh my gosh, the doctors will never let people just have unfettered access to their schedules. And then the next question is, oh my gosh, the patients will screw it up. They'll never be able to figure out all of our appointment types. And you say, God, that's really interesting, but what if we let patients have access to scheduling online 24/7? You know, what's the worst thing that could happen? And so the problem is we would have to simplify it, right? We couldn't put 600 appointment types on. We could only put 2 or 3. Because the reality is every appointment type is really built on a backbone of either 15 minutes and 30s or 20s and 40s. The patient doesn't care about our 600 appointment types. They're not buying appointment types, they're buying time, right? But we think that they're buying appointment types, and they're not. They're buying time. So let's sell time. Let's say, here's 2 appointment types or 3 appointment types, that's what you're buying. So an interesting thing happens when you allow patients to book their own appointments, as we've seen in the last year. Your no-show rate gets cut in half. Why does that happen? Well, think about it. In a manual phone call, it's a negotiation, right? It's, hey, can you do Wednesday in the morning? No, I can't do Wednesday in the morning. What about Friday afternoon? Can't do that. How about the next Tuesday in the morning? Yeah, I guess I could do that, okay? So maybe 3 times, and then we settle on a time. With portal scheduling, I get to see, here's 10 possible appointments. No good, scroll. 10 more, no good, scroll. Ah, that's the one I want. Okay? You got to see a lot more options, and then you got to pick the one that you actually want. So moving on to video visits. So on our roadmap and some video visits that we've piloted right now, there's research that kind of suggests that, you know, probably 60 to 70% of physician visits don't really require a physical exam. So why do we do that? So with a video visit, the idea would be if somebody's had, you know, surgery or something on their hand and they live 2 hours away and we're in a rural part of the state, rather than making them come back in for post-op visits, could they just do a video visit and show us that they can move their hand, or that you can have some kind of communication with the doctor, and, you know, $40 later, and if it's a post-op, it's already covered, but other visits, $40 later, you've had your visit, you didn't need to drive in. And people always ask, oh my gosh, is insurance going to cover it? Realize that insurance companies right now think that they're the aggregator. They think they're the center of the universe. They're kind of the king, right? When's the last time a king led a revolution? If you're going to wait for the insurance companies to think it's a good idea, you're going to wait a long time. And so we said, that's interesting. We're just going to do it for $40, and the insurance companies can come along. And they will. But right now, it's just $40, okay? Well, there's a lot of people that probably don't want to do a video visit with a physician because all of us have FaceTime on our iPhone, and how often do you really use it, honestly? We've kind of become the post-telephonic industry or world. We kind of like to text and email. It's just lower energy. And so we've got the option for $40 of doing an asynchronous visit. And with an asynchronous visit, it goes something like this. Hey, doctor, last year you gave me this for allergy season and it really worked, and it's allergy season again. Could you just call this in? And they can do that 40 minutes or $40 later. And you can attach pictures and you can attach video. Also on our roadmap is online forms. So nothing screams at me that I'm not the center of healthcare than having somebody tell me, and come to your appointment 20 to 30 minutes early so you can fill out some forms. It's like, really? That's great, you know, because healthcare is so inefficient. We bake efficiency into the process. We know that you're going to have to do that, so we're going to build waiting rooms and dedicate space to our inefficiency. So how about something novel like just-in-time patients, right? That just show up when it is their appointment and they don't have to sit in the waiting room. And online forms allows you to do that. So we push the form to you through your portal. You can fill them out online, and then your visit goes much easier. Now, this is where it gets really exciting. So do you know how when you go to your dentist and they can tell you in 6 months that you have a cleaning that needs to be done, or you go to your vet, or your pet goes to your vet, hopefully, and they can tell you when the shots are due. How come in healthcare, we can't tell you based on your age, sex, and medical condition the 7 things you should have done this year? It doesn't happen because we're a fragmented cottage industry. But in an integrated delivery network, we could create a dashboard like this, and you could see red, green, or yellow what you're overdue on. And so now we've gone away from being this stimulus response industry that just says you're sick, you call us, we make you better, to saying, you know what? You may not even know you need these 7 things, but we're on it. And we're going to send it to you, and you're going to be able to get that managed. So what's exciting about this is we're also building in our roadmap something that we call our points economy. So when we create these portals, we want to be able to give people a nudge to consume healthcare in the way that we want them to consume healthcare. So it looks something like this. If you call us on the phone, and if you come in person for a clinic visit, you get no points. If you schedule online, you get 5 points. If you schedule online and do your visit online, you get 10 points. If your health dashboard is all green, you can get 500 points. Okay? Now, if we partner with employers and say, if somebody got up to 1,000 points and they had all the classes you had assigned to them online, their smoking cessation or their rethinking drinking modules, if they had all that done, would you take $1,000 off their health premium? Okay? So you can start to see how this can become a great patient engagement tool. The other piece about this, which is kind of exciting, is today we have a lot of people in a fragmented fashion doing all these activities, and so the employer's doing a wellness program and they've got their Fitbits, and then the health system is doing something different, and it's all fragmented. But what we intend to do here is pull in all the wellness components so that your Fitbit, your biometric devices all feed into this one patient portal, so that now the patient knows if they're red, green, or yellow. So the big hot topic these days is registries, right? And so everybody's saying, hey, we'll have these registries and they'll track data, and then the health coach will look at it and they'll call all these people and nag them to come in for their colonoscopy, and then the doctor will be able to see the registry as well. Well, where's the patient's view of that data again? We haven't even conceived of that very much. And so now, through the portal, you've got the patient's view of their own data. They know if they're red, green, or yellow, or what they need to be doing. So here's the analogy. Think back 20 years ago when we had banks that you would actually go into because you actually wrote paper checks. Our relationship with banks was 100% bricks and mortar. And over the last 20 years, for most of us, 90% of our relationship with our bank is online. Okay? Now imagine if a bank had said, yeah, we're doing that online thing, but you can only pay your mortgage online. If you want to pay your utility bills, you got to go to that other bank. That's essentially where we are in healthcare today. Yeah, I can do my Fitbit over here through this app, and then you can do then you can do this on this app, and it's totally fragmented. There has to be an aggregator. There has to be a convergence point where all these things feed in. Otherwise, the patient's never going to be engaged. It's always too complex. All right? And the patient portal ends up being that engagement. And we believe that over time, that portals will be able to take us from a 0 online relationship or mobile relationship to a 50 to 60%. And so it might look something like this. We know, and we've been reading about for years and years, this migration from inpatient to outpatient. Okay? And mobile is this tiny dot, okay? Well, what's going to happen as mobile gets even bigger and as mobile starts taking visits out of the bricks and mortar doctor space, right? As remote monitoring starts keeping people out of the hospital and not having readmissions, all right? Mobile is going to become even larger and it's going to become even bigger. We're essentially creating a system where you have clicks and mortar. And so we see a lot of online organizations that are saying, hey, I can do a doctor visit online. Well, that's cool. What if they actually had something really wrong with them, though? Then is it just go to the emergency room? So we see a mobile strategy as something that can become a category killer for integrated delivery systems where they can compete because they have both the bricks and the mortar. So the question that always comes up is, oh my gosh, that sounds really cool, but our hospital is not in Silicon Valley or in Columbia, Missouri. How am I supposed to be innovative? This is kind of facetious. And so the good news here, I have great news for everybody, but it takes us to doing a little thought exercise. And so the thought exercise is, think back to when you were 3 years old. And this is going to be a long journey for some of you. But imagine when you're 3 years old. There was a study done on 1,600 3 to 5-year-olds that was done years ago, testing their divergent thinking skills. And on the divergent thinking skills, it's something like this. Convergent thinking is 2 + 2 is 4. The capital of Louisiana is Baton Rouge. Divergent thinking is, give me 10 uses for a brick. And you could say, well, a brick could be a doorstop. It could be a keyless entry system into a car. It could be a lot of different things like that. So they tested these 3 to 5-year-olds on their divergent thinking skills, and here's what they found. 98% tested as creative geniuses. But then school started. And here's how it flows down. We get to 32% by the time they're ages 8 to 10, 10%, and then all the way down to 2%. Now, invariably, people will ask me, in that 98%, who were those 2%? What happened to the 2% that weren't creative geniuses? I'm happy to tell you, they landed on their feet. They are writing code for Epic at this point. So I just think it's good when everybody wins. I think that's good. But the point of all this, right? The point of all this is that you probably have the wiring in all of your employees and in your organization. You probably have the wiring mentally to be enough of the creative genius that you need to be to destroy what we've built to create something better. It's there. You already have it. All right? But you have to destroy all this convergence and this convergent thinking and this structure that you've created so that we can put the patient at the center. So in closing with that, I would tell you that innovation in healthcare is not going to be about addition. It's not going to be about ICD-11 that now has 1 million codes. Innovation in healthcare is going to be about subtraction. Period. The thing that you will find when we put the patient at the center is that we're going to create elegant solutions. You know, beautiful solutions don't draw attention to themselves. They just are. You just feel it, you just use it, you don't even think about it anymore. Okay? You look at why Blackberries are extinct. 40 buttons. iPhone, 1. You look at the reason your kids don't say, oh, let me Yahoo that. They Google it because it's elegant. It just is. It just works. So I want to thank you for your attention and your time, and I wish you happy creative destruction in your organizations as we try and put patients at the center of healthcare. Thank you.